Hey there folks, it's Ross here from OpenAirway. I'm currently in the UCT Anesthesia Airway Skills Lab, and in this short series of videos we're going to be talking about supraglottic airways. Now these videos are definitely going to be brief and they're likely to be far from perfect, so if there's anything you disagree with or there's stuff that you'd like to see or there's important stuff you think I've left out, please put in the comments and we'll evolve them over time. I'm aiming to keep them short and sharp and to the point. So in this video we're going to talk about what are supraglottic airways and some examples of the different devices and the different classes. Subsequent videos we're going to go into things like the precautions, the placement, the use, the troubleshooting, intubating through supraglottics, and some specifics on specific types. First things first, what's a supraglottic? Well, if you're a purist and you're writing a textbook, then any airway that you insert which does not traverse the vocal cords could be classified as a supraglottic airway. So something as simple as a nasopharyngeal or an OPA or a cuffed OPA could qualify as a supraglottic. But for the sake of the discussion that we're having and for our clinically relevant work on a day-to-day basis, we're really talking about something which is inserted into the larynx and maintains an airway. So let's eliminate these from the discussion for the moment. Right, here's a whole different spread of supraglottics, and this is actually just a fraction of what's available on the market. There's some quite popular devices which I don't have examples of here in the lab, but I've got examples of the majority of the broad types with what's important. Now the classification of supraglottics is contentious, and there's some lovely stuff to read about this in the literature. There are two common things that we talk about. We talk about either the sealing mechanism of the device or we talk about the generation of the device. Now, if you're thinking about sealing mechanisms, there's a nice classification by Miller which really looks at three primary mechanisms. And the first primary mechanism is that of something like the classic LMA, where you have got a cuff that sits around the larynx and that generates your seal. So this is a cuffed perilaryngeal sealer. Another option that you can do is you can have a cuff that seals right around the pharynx. So here's a Cobra PLA, and you can see here it's got an inflatable cuff that sits in the larynx and it's sealed, in the pharynx, and it seals right around the pharynx. So this is a cuffed peripharyngeal sealer. Another example of this would be something like a king laryngeal tube airway or a combi tube. And some of the peripharyngeal sealers have also got a cuff which inflates and helps to seal off the most cranial end of the esophagus, and so they've got a second cuff and functions much in the same way. And the third class of device is that which doesn't have an inflatable cuff but is shaped to fit the anatomy. So here are two different examples. This is a slipper airway and this is an I-gel, and these are anatomically pre-shaped sealers. So they don't have a cuff, they're cuffless devices. So cuffless, anatomically pre-shaped sealing devices. So that's the one classification according to the sealing site, and you can then break them down as to other characteristics they've got, such as allowing intubation, such as protection against aspiration, etc. Another method of classifying the devices is talking about the generations. Now, this has become quite a commonly used way in the literature, and it's useful to us particularly when we're using supraglottics as rescue airways or in the emergency setting to understand what's meant by first and second generation devices, because that's on some of the protocols. So the generational principle is that a first generation device, which perhaps the quintessential one is the classic LMA, has got a simple breathing tube and then usually some kind of mask which sits around the larynx. But something like the slipper, which is the simple breathing tube and sitting around the larynx without a cuff, would also qualify as a first generation device. The second generation means that there is some method of providing gastric drainage and prevention against aspiration. So here are a couple of second generation devices. Perhaps again the quintessential one would be the ProSeal LMA, and you can see that there's a drainage tube on the tip which comes out over here, and this allows any fluids which are passively regurgitated to come out, and rather than going around the bowl and getting into the patient's airway. One can also place a nasogastric tube and decompress the stomach, suction out fluid, etc. So that characteristic of providing gastric drainage and enhanced features again to protect against aspiration is what makes something a second generation device over being a first generation device like this. And that obviously is an advantage to us in the emergency setting because our patients are at high risk of aspiration, and where we're being forced to ventilate through the device, it's nice to be able to decompress any gas or air that's got into the stomach. Now, there is a proposed third generation, and there are a couple of devices where we talk about a third generation, although this is not well accepted in the literature yet. And the proposed principle behind a third generation device is that it provides some kind of mechanism for dynamic sealing. So a property that's been identified is that if you have a tightly inflated cuff or a rigid device that's inside your patient for a long time, that can start to cause pressure necrosis, nerve injury, etc. So a number of these devices, there are about 3 different ones, the 3GLM, the Elisha and the Basker, have either got a cuff where the inflation pressure changes as the ventilation changes, or a flange that expands and contracts as you ventilate. And of course, you can see that as you go up in the generations, you incorporate the features of the previous generation. So the first generation, simple breathing tube. Second generation, breathing tube with gastric drainage and protection against aspiration. Third generation, breathing tube, gastric drainage, protection against aspiration, and some kind of dynamic sealing mechanism. Then, just to throw things into the mix, you also get devices which are specifically designed as supraglottics to allow intubation. And perhaps the most classic example thereof is something like the fast track intubating LMA. This is the reusable version of it. You also get a disposable version, and this is specifically designed to direct an endotracheal tube through it and allow intubation of the patient with or without the use of a fibroscope. You have very varying success across all the different devices if you try and do blind intubation. Most devices will allow fiber optic guided intubation with some variations on the theme, and that will be in a later video. And then there's an even more advanced concept behind intubating supraglottics, and that is adding some kind of camera capacity or visual capacity to a supraglottic, which allows you to intubate through the supraglottic under direct vision. We'll cover that in a later video as well. So, widespread of supraglottic devices, sealing in all sorts of different places, allowing gastric drainage, allowing protection against aspiration, and potentially allowing intubation.